right. Hello, everyone. I want to welcome everybody to the next episode of the Prime Time Mindset Podcast, where we dive into habits, mindset, and behind the scenes stories that fuel success in fitness, business, and life. I'm your host, Jarrett. And before we jump in, I want to make sure everyone knows what the show is all about. Prime Time Mindset isn't just for athletes, it's for anyone showing up every day to be better than they were yesterday. It's about preparation, pressure, and progress, and how to push through the moments that matter the most. Today's guest embodies all of those elements. Dr. Sarah Vij, I hope I'm saying that right, has a passion for teaching and patience. And patience, I've described her as straightforward, thorough, and compassionate. So, Dr. Vij, welcome to the podcast.
Thank you so much for having me. Excited to be here.
Good. So just to open up, why don't you tell us a little bit about yourself? And I always find it's better for somebody else to describe themselves than for me to just read off a dossier of all of your credentials. So tell us a little bit about yourself.
Sure. So my name is Sarah Vij. I'm a urologist. I'm fellowship trained in male infertility and sexual medicine. I was at the Cleveland Clinic for several years and just joined University of Texas at Austin's Dell Medical School 6 months or so ago to build a men's health program in Austin.
Awesome. So, what kind of brought on the idea for you to treat men infertility and sexual wellness? Where did that really come from?
Sure. So we get a lot of exposure to many different things in our training, even pre-residency. And then once we get to urology training, and what I really liked about the infertility and sexual medicine space is it's all about quality of life. So we don't talk so much about quantity of life and death and things that are, harder conversations. It's all about trying to improve people's quality of life. So helping them have a baby, helping them, feel better, improving their sexual function, that kind of thing. So I felt like it was very gratifying and I could really help people sort of in the near term.
Yeah, we found that with a lot of the game day owners are, that is one, not the owners, but the personnel that come over from the traditional medical space. They feel, hey, I'm really helping this person improve their lifestyle, not just keeping them alive. It's great, obviously, but they have tweaks or need changes, and it really, we're really helping them have a higher quality of life. And that kind of means a lot to a lot of people, right? So that makes sense. Offhand, I saw on one of the things I read that you guys offer is reverse vasectomies. And a weird question came to my mind when I read that. And I just wonder, I have a vasectomy as well, but I always wonder how many of those reversals are people that are with the same partner. Because I could see, they get it, they change partners. It's like, oh no, I want to have a kid now. Does that really happen a lot with the same partner?
So it definitely does happen with the same partner. So that's, vasectomy regret. The couple decides, they thought they were done having kids and they changed their mind. So that does happen. That's definitely the minority. If you look at all the reversals we do, about 90% are divorced new partner. A very small percentage are young people who thought they didn't want kids at all, made that decision when they were single or married and then changed their minds. And then a small percentage are people that, a couple that made the decision together and has now changed their minds.
Yeah. I would see that. I did not have vasectomy regret when I did mine. My kids are old and good to go. So we're done there. Okay. So in the world of erectile dysfunction, it is a sensitive topic, obviously, for men. And, even as a guy owning the clinic that is helping guys do this, it is a monumental task to get them to come in and talk about it and feel safe and feel comfortable. So how do you go about doing that and making these guys open up about something that is so sensitive?
Sure. So I think, this has evolved with time because just like anything, it takes practice. So I've been doing this for long enough now that I think I have a little bit of a better sense about how to make them comfortable. But the big thing I do is I just normalize it for them. It's really common, especially as men age, almost everyone is going to have some degree of erectile dysfunction, whether it's requiring treatment or not. And I tell them I talk about this all day long. So for me, this is just my job. There's, there's nothing funny about it. There's nothing embarrassing about
Yeah.
it. Um, so, I think I'm sensitive to the fact that I'm a female treating male patients. And, my hope is that if they've scheduled with me, they are, comfortable talking to a woman. But I've had several patients, after the visit say, thanks so much, doc. I really was really nervous about this and really, put me at ease. And um, so again, that can take some time, but I try to just keep it very sort of professional. And it's just like anything else, just like talking about your high blood pressure or
Yeah.
diabetes, going through treatment options, asking how it's affecting your life and what your goals are, um, and normalizing it for them. It's just so common.
Yeah. I had this conversation with another physician, and I said, I think, at least for me, I think deep down, men may not realize it, but I think they're more comfortable speaking to a woman because women are it's just more nurturing and more, you guys listen better. It's just,
Yeah,
there's just something. Yeah.
yeah, I have had patients say that. I think there's also like men want to be like around other men, sort of like show their manhood or I don't know,
Yeah.
something like that. I think everybody is different. Truthfully, there's probably people that have preferences, people that don't care, but um, I have not found my gender to limit my ability to take care of patients or build a practice at all. So,
Yeah. And one of the things you mentioned, it seems like there's three pieces of education that guys have to go through, right? There's the, what's happening with me, right? What is causing this? Then there's you mentioned the part of, you feel singled out, right? You feel like you're the only person this is going through because nobody talks about it. We don't talk about this stuff, and honestly, guys, we go the opposite way. We will boast about things that aren't happening just to to not seem like we're the only ones. And then there's the piece of getting them to, all right, this is why it's happening. You're not the only person, and no, it's not going to fix itself, right?
right.
We're at this point. Do you find that you kind of have to walk people down that path of taking these baby steps to get them to understand that?
Yeah, I think so. I mean, as a urologist, you do get referrals of people that have carried the diagnosis, they've exhausted treatment options. Maybe they're coming to see you for a penile implant. That's a different conversation than a guy this is a newer experience for them and you're trying to break down the disease process, explain, why they might be having difficulty and then going through treatment options. So for every patient, it's a little bit different. I think one of the hardest things for patients is sometimes we don't have a precise explanation as to why. So you can list off some of their risk factors. You can do a Doppler study and look at their blood flow. But even still, patients always want to, I have a bacterial infection and we're going to treat it with antibiotics. It's not quite that clean with erections. And so um, sometimes it's accepting that like, okay, this is a problem I have. I don't know exactly why, uh, but I'm accepting it and I'm ready to look at treatment options.
Yeah, yeah. And so as with all of the things that at least we do, I know you've been to the game day up in Austin, but how do you link for the customer or the patient? How do you link testosterone with ED and
Sure.
kind of bring it all together for them and say, you're walking in with this symptom, but we also need to, at least take a look at this to see, because they could not be related.
Right.
How do you walk them through that?
Sure.
And what do you explain as the links between how they're working against each other or for each other?
Right. So this comes up all the time. So we know that testosterone plays a role in sexual function. It also plays a role in so many other parts of the male and the female body. So I think sometimes people think it only plays a role in sexual function and bodybuilding, right? It kind of gets this almost like a bad reputation. But testosterone is important for bone health, cardiovascular health, diabetes prevention, like mental acuity, so many things. So I explain, it has a role in everything, really for a male. And it does have a role in sexual function, but sort of to a point. So men with very mild erectile dysfunction, they're managing on their own, but maybe they're losing their erection. They need a low dose, medication to help them. if you check a testosterone in that guy and it's low and you treat it, he may do well and be able to get off medical treatment and just be on his testosterone supplementation. But for patients with more moderate to severe ED, the pills aren't working anymore. Um, Generally, normalizing testosterone in and of itself is not going to cure their erectile dysfunction. So I do still talk about testosterone treatment because, again, it plays a role in things other than just erections. And it's important to address it, but it's generally, I think men are hopeful, like, oh, my testosterone's 250. Like, if we get it to 700, my ED is going to go away. But that's not the case for the people that have more, moderate to severe erectile dysfunction.
And what are some of the yeah that well let me back up. So for those guys that have the mild to moderate, how do you kind of help them understand or distinguish between um, the aging, there's normal aging that is going to take place. So, you mentioned this up front, right? Almost everybody at some point has some form of erectile dysfunction. How do you help them distinguish and walk through? There's aging, and then there's more severe, there's more issues, there's lifestyle factors that you're doing that may be playing a role in this. How do you walk them and explain that to them as well?
Yeah, so I try to break down sort of each patient's modifiable risk factors, right? So if a patient's had a prostatectomy, it's not modifiable. It's a risk factor for ED. They generally know that, but we talk about modifiable risk factors. So low testosterone is one of them. Obesity, um, diabetes that's maybe poorly controlled. Can they get that under better control? And I emphasize to them that, like, not only is this going to help your sexual health, but it's going to help everything, your longevity, right? Your time on this earth. So get their buy-in, in that way. Um, so, I really do try to focus on things that we can modify, but I explain to them, a lot of this disease process is irreversible. And so, you're a 60-year-old guy that's had diabetes and high blood pressure, high cholesterol for 15 years, and you all of a sudden get all of that under perfect control and you lose 50 pounds and you're on testosterone, you're feeling good. That's great. And that's going to make you live longer on this earth and feel a lot better and enjoy your life more. But that may not, decrease the calcification that's already occurred in those blood vessels. And that's okay because we've got treatment. But you don't want to set false expectations, but then it's also a balance of trying to motivate people to take care of themselves.
Yeah, yeah. No, it's you try to walk that line with some of the guys that walk in that come in with I hate to say it, but they've waited so long to come in for treatment, and you say, well, we have to clear up some other issues first before we can even start treatment,
Right.
and then that treatment is only gonna maybe only get us so far, but you're gonna feel amazing compared to where you feel now. But
Right.
it's only gonna get us so far. You mentioned treatments. What treatments are you seeing, or are you using nowadays, or something that's new on the horizon that you're excited about, or that you see some real promise with for some of these guys?
For erectile dysfunction, yeah.
Mhm.
So there's definitely a menu of treatments. We have a lot of treatments out there that are still um, in sort of experimental phase. So we're still gathering lots of data. So things like shockwave. There's lots of studies going on to determine, who are the best patients for this. What's really what do you counsel them on a reasonable expectation to have from treatment? I think the data is still, fuzzy there.
Mhm.
Obviously medications, Cialis, Viagra, those have been around forever, very effective for the right patient. Injection treatment also been around a really long time, can be very effective. Penile implants also, been around, and that's really the only sort of curative treatment option in terms of, giving somebody a reliable rigid erection, on demand, but that requires surgery. And the implants, the devices themselves are evolving. The companies are working hard to make them, easier to use, easier to place, and so that's those things are evolving. And so there's a lot of other stuff out there, combining medications or trying to get fast acting or intraurethral suppositories. Um, a lot of them are sort of modifications of our current available options. Um, but I think just getting patients to be open to trying different things, maybe other than just a Cialis or a Viagra, as part of my job, to get them on board if that helps them reach their goals.
You guys do the shockwave sound wave therapy.
We don't have it set up yet at our clinic because it's so new.
Hmm.
But the goal is to offer that. At my prior job, we did offer it,
Yeah.
and we see some good results in patients with mild ED.
Hmm.
Again, I think the moderate to severe patients are just not going to respond to some of these treatment options, just like they don't respond to Viagra and Cialis. And so I
Yeah.
just try to be data driven and show them like this is what the studies show, and there's no risk in the shockwave, like zero. It's just there's some cost to the patient. So some people just say, you know what, let me give it a try.
Yeah. Yeah. We've used it here, and we've seen some really good progress with the folks after like the third or fourth treatment.
Sure.
You'll see some, but again, like we said, it's our clinicians make sure to tell them based on your shim score if you're a good candidate or not. If
Right.
it's really severe, I probably isn't gonna help you too much. But
Right.
it's a good
And
point.
I think sometimes something like shockwave also just helps to get patients bought into their like to their long-term goals. So, all right, I'm going to go to this clinic once a week and get shockwave and pay for it. And so I'm going to also try to lose some weight and be better about my diabetes and quit smoking. And so kind of like these things kind of work together, I think sometimes to um, just motivate patients to really sort of try to turn their lives around from a health standpoint.
That's a that actually that's probably one of the biggest points that we we need to emphasize as well with men, because men want, my carburetor's busted, I can go, it's going to be fixed in 2 hours and I'm out, I'm done. So we expect things or want things to be done and fixed, not have to go through this series of treatments.
Right.
And with everything we talked about, it's a series of treatments for you to get there. It's not
Right.
gonna, you know, um, we didn't go get overweight overnight. Don't think you're gonna get rid of it overnight. So
Right.
um,
Right.
that's a very good point. Um, what other avenues or what other things that are you seeing that help guys? Not in the ED, maybe testosterone, maybe some of these other functions where you're helping some of your patients with some of those other treatments.
Sure. So testosterone, we've kind of touched on this already, but I think for some patients it really can be transformative. I mean, if you're going to the gym every day, you're doing all the things right, you're eating well, but you can't make any progress if your T is 150. So I think that can be really transformative. I talk to men a lot about weight loss, and now there's drugs available now, pretty readily available to help people with weight loss. So I think that's a nice, it's nice progress that we've made. I think Game Day offers some of the peptides, Ozempic, et
Mhm.
cetera. And so I I think sometimes patients don't always make the connection that obesity can affect their sexual function.
Yeah.
Sometimes, again, that's the thing that like makes it click. Same thing with my fertility patients. Obesity is a risk factor for infertility. So they're trying to get pregnant. It's devastating for them. Maybe that's what motivates them. Maybe the partners are going to do it together because they want to be in really, good, fit shape when they've got a toddler running around. So I definitely spend a lot of time about just, healthy eating, get a fitness, or a calorie tracker, find out what you're putting in your body, watch your protein intake, and try to make sure you're getting enough protein, lift some weights, go for walks, like just basic, like, wellness tips.
Yeah.
That comes up a lot in these conversations.
It does. Yeah. We try to do the same thing, make sure that this is not it's not going to do it by itself, right?
Right.
You have to put in some effort. You have to do some things to get you there. Are there any combination and I know every patient's going to be a little different. It's going to be trial and error to a certain degree. But have you tried certain combinations with, let's say, overweight patients where, hey, a testosterone and this peptide, or a testosterone and this GLP-1 or something tends to have some pretty good results as opposed to just one of them by themselves? Have you seen any of that?
Yeah, so I don't prescribe the GLP-1, so I,
Okay.
rely on colleagues for that. I don't know the newest data, but I have to imagine that if a man has low testosterone and is overweight, that doing those things in combination is gonna be better than either alone, or that treating their testosterone is going to help the effectiveness of the GLP-1. Because the whole thing with GLP-1s is you can take them. That doesn't mean you're like sitting on the couch and the weight's just going to fall off. Like you've got to be eating high protein, you've got to be moving, you've got to be muscle, lifting, because your muscles will also atrophy. And the testosterone is going to help with that. So I think for the patients that, that meet the metrics for treatment, trying to help them as best we can, makes all the sense.
Yeah, I agree. I agree. So I guess one of the last questions I'll ask you, which I definitely appreciate your time, and I know you have other appointments, but is there any? We probably started through this a little bit, this question with all of this conversation, but any advice you would give to guys that are on the fence or thinking about or are unsure if they have ED issues or if they have low T? What is just something you would tell them to
Sure.
kind of get them motivated?
I think if it's sort of occupying any of your brain space, you're thinking about it, you're wondering, do I have an issue? Should I just get seen? It's so easy to get care now for these problems, which is very different than it was 20, 30, 40 years ago.
Yeah.
Um, clinics like yours and, lots of specialists out there like myself that are happy to see these patients, and you get your T checked and it's totally rock solid. Okay. You've got that data and you don't have to worry about it.
Right.
And so I think, there's no harm in checking. You can even, you can check these labs, at home now. There's kits. And, I just, tell people go see a clinician, try to get some, clarity. Don't diagnose yourself on Google and treat yourself on Google, because these days you can do that. Um, so, if it's on your mind, you're thinking about it, like I said, taking up any brain space, just get it checked. It's so easy. And we've got so many treatments to offer, especially with testosterone treatment, so many different ways you can normalize testosterone: pills, shots, creams, pellets, nasal, options. So there's different treatment option for everybody.
Hmm. Awesome. Well, I appreciate that. The last question I have is really kind of a personal one. If you surpass all of our guests, since we're trying to be a prime time mindset, when things get tough for you or you're in a tough moment, would you kind of tell yourself to maintain your prime time mindset, your peak performance mindset? What do you tell Sarah? This is what you
Yeah,
got to do, girl.
right. you know, uh, Everybody has challenges. They're almost often short-lived. For me, that I know that what always helps me kind of get out of my rut is being physically active.
Mm,
I was a college athlete. It just like always brings me back to my sort of inner peace, and going to the gym, going for a run, lifting some weights, always kind of just gets me back on track. And so just getting back into my normal routine and moving my body, it just helps the mind so much.
awesome, awesome. What did you play?
I played soccer and lacrosse.
Oh wow. Oh,
Yeah.
that's
Long
that's
time ago. Long time ago.
well, but
But
that's a lot of physical activity. So that's awesome. That's awesome. Where'd you play?
I played at Amherst College. It's a Division 3 school in Massachusetts. So not Division 1. So don't be too impressed.
Yeah, look, I'm impressed. Regardless, look, you played, you were in it. So how can you tell the listeners or those viewing this how they could find you if they want to know more about what you guys are doing up there in Austin and your
Sure.
just what you're doing?
Yeah, so I'm seeing patients at Dell Medical School at our health clinic campus. It's just south of the football stadium downtown. It's a new clinic, so we're trying to get patients through the door. We've got good availability. You can look up the practice online if you just search my name, and call and get in.
Awesome. Well, thank you, Dr. Vish. I really appreciate it. And to everybody listening, thank you very much for viewing, and send it to a friend. If you have somebody else that's building something on their own, we wish them the best. And other than that, thank you very much, Dr. Vish, and have a great day.
Thank you so much for having me.
All right. Thank you. Bye-bye.